Good afternoon and welcome, and thank you to all who are joining us for this session physically in Barcelona, and also welcome to all of you who have joined us online, including some of our speakers. I would like to introduce myself as your chair for this session. My name is Katrina Mullen. I am here representing the Association of European Border Regions. The association is 50 years old this year. We have been promoting and advocating cross-border cooperation across Europe since 1971. So we've just had our 50th anniversary celebrations about 4 weeks ago, actually, in Arnhem in the Netherlands. AEBR has a membership which spans the internal and external borders of the European Union. We have members in over 70 border regions who actively contribute to our work. And one of our key policy areas of focus has been for approximately 15 years the area of cross-border cooperation in health. We have a cross-border health task force which draws membership from, again, across Europe. And we most recently have been involved in carrying out a study for DG Santé on the issue of patient mobility in cross-border regions. We are in the process of completing that study. So we're very pleased to be able to join you this afternoon. My colleague Martin Guillermo Ramirez, who is the Secretary General of the AEBR, is also joining us virtually this afternoon. And we're very pleased to be able to contribute to and facilitate the discussion on a very, very important topic, which is that of health cooperation across borders, particularly in the wake of the COVID-19 pandemic. At the moment, in 2021, we are emerging from the crisis phase of the pandemic. And I often think that it's important to remember that this time 100 years ago in Europe, our predecessors were contemplating the end of a pandemic and emerging from a pandemic. And as we look forward to post-COVID cooperation and a Europe that is post-COVID, a Europe of the regions, I think it's important to ask the question as to how we can be good ancestors and how we can adopt and maintain some of the innovations which took place as a result and during the crisis, which hit all of us equally. It's often said that disruption breeds innovation. And we know that in the case of COVID-19 and health cooperation, that cross-border cooperation was extremely important and life-saving in some cases. And we're going to hear from some speakers today about just how important that cooperation was for the urgent care that was delivered during the crisis. We also know from AEBR's research that the civic authorities in border regions played a very important role in supporting the health service in border regions across Europe in a number of different ways, not just through politically raising the issue of cross-border healthcare collaboration, but also in responding to the crisis through responses such as procurement of PPE, negotiating obstacles when borders were closed, and generally trying to smooth the disruption and participate in what was a collective effort across our borders to support patients. The session today will look very much at the theme of territorial cooperation in health services, and the pandemic again has highlighted the importance of place and the importance of relationships in a place and on borders between healthcare providers, insurers, and civic authorities. So I am very pleased to also extend our thanks to the Luxembourg Hospital Federation for hosting this session. And on that basis, I'm going to give you some housekeeping points, and then I'm going to welcome our first speaker. So the running order today will be that we have 5 speakers. Our first speaker will be Philippe Turc on my right, and we will also have some speakers joining us virtually. Following the speakers, we will have a question and answer session. For those joining us virtually today, you can send your questions by clicking the Q&A tab on the right side of your screen. For those of us who are here in person, you can send your questions by first downloading the Congress app, and once you are logged in, you can click Q&A from the home screen, and select this session to send your questions. And if all else fails, we have a mic and you can ask questions in the room. To get to know the presenters more, you can look at the section about this session in the programme for the conference, and you can view profiles of speakers in the Congress app. I'm now going to move to introduce our first speaker, who is Dr. Philippe Turc, who is chairman of the board of the Luxembourg Hospital Federation and coordinator for Luxembourg hospitals in the National Task Force during the COVID-19 pandemic. And just a quick reminder to our audience that we will take the questions at the very end after all the speakers have contributed, but please feel free to send in your questions as they occur to you, and we'll receive them here as the speakers are working. Philippe, I'm going to hand over to you. You're very welcome. Thank you very much.
Thank you very much, Catriona. Thank you for your excellent beginning of the chair of this session. A big thank to IHF to give us the opportunity to present here our Luxembourgish situation, which is quite particular, as we'll see in the coming minutes. I'm going to present our experience of the COVID-19 pandemic, and as you see on this map right away, that Luxembourg is an extremely small spot on the map of Europe. We have not even 1/10 of residents of Catalonia, so it's definitely a small place. And the national policies we are surrounded are taken in Paris, Brussels and Berlin. So we deal not only with ourselves, but we deal with 4 national policies, and this in the pandemic crisis. The definition of the Grande Région around Luxembourg has been changing over the years. Originally in France it was the region of Lorraine, which was changed to integrated in the Grand Est, which is a much larger portion including Alsace and Champagne. For Belgium it is the French-speaking part, and for Germany it's 2 Länder of Rheinland-Pfalz and Saarland. So that is the territory we are talking about in the coming slides. Luxembourg City, definitely a small spot. We have in Luxembourg an even smaller place around with a small village along the Moselle in the vineyards, which is called Schengen, which should be a concept for most of you. The Schengen Agreement is now dates from 85, so it's a very, very old story. And initially, the intention was to guarantee free circulation of people, of goods, and of services. So it's a good moment to remember this historical small place. It's, and you must say, a nice village if you come to visit Luxembourg. Our economical situation, so I'm especially happy to see that Mr. Bertrand Levray is here today. He's in a similar situation in Geneva. He was talking about that during the main session this morning. We have, for not even our million residents in our territory, we have 470,000 jobs in Luxembourg, which means and I'm not going to talk about traffic jams, but you imagine the 214,000 people, cross-border everyday commuters, which come in the morning and go back in the evening. So that's our situation for the whole of the economy. If we zoom that on the healthcare system and the hospital system, you see that 56% of our nurses and doctors do not live on the territory of Luxembourg, the Grand Duchy of Luxembourg. So you can imagine that when we are speaking of border closures, that we get in a very stressed situations. So this is the context. one of the difficulties we had is compare numbers and figures. Question of definitions. What is an intensive care unit bed? What is don't have harmonized definitions in the 4 countries. So data collection initially was quite a challenge for us to make sure that we could have figures that we could compare. The definitions vary from one country to another, and at the beginning there was lots of discussion about monitoring the whole story. In the end, our figures include the whole of Belgium, the 2 Länder of Germany and the Grand Est in France, and we're going to concentrate on admissions in intensive care units in this Grande Région. These figures are going to be discussed in a few minutes. The yellow Luxembourgish curve looks like almost the average of the Grande Région, knowing that at the first wave, so means March and April 2020, we took 10 intensive care patients from Grand Est to help them because they were overwhelmed and couldn't cope anymore. It's getting more interesting when we have a look at the last year, beginning in September, October. I could simplify and say that the first wave was easy in the sense that we stopped all other activities, or almost all other activities in the hospitals during 3 or 4 weeks. During the second wave, I think many institutions made big efforts to keep normal care running apart from the COVID workload. So if we zoom a little bit on this area here and we look at the details per country, you will see how variable these curves were. I must say these numbers are all data in proportion to the Luxembourg population. We had to reduce the numbers to be comparable. So this is the blue, very strong wave in Belgium, a long-lasting red wave in France, apparently much better curve in Germany, and somewhere in between the Luxembourgish curve. Now, how do we explain these different curves? I'm coming to that later in 1 minute. What was specific to Luxembourg? I think we had a much more aggressive way to chase the virus. We offered the whole population large-scale testing. We had more than 6 times the number of population which were tested. Even asymptomatic people could have a free PCR test, which means that we identified high numbers of infections with people who are asymptomatic. These asymptomatic went in quarantine. Second, we were very aggressive in tracing. For each positive case, we were working up 5 contacts. And so there we found again the virus in many asymptomatic patients, and these people were not real patients, they weren't sick at all, but we managed very severe quarantines. And I think this is one of the messages which was, I believe, helpful to keep things under control. The monitoring was difficult, as said initially, because of lack of harmonization of definitions and equipments. And in the coming slide, I will come to a very interesting question: is what kind of policies and restriction measures were taken in the 4 countries around us, which probably explain these funny curves we have just seen. And here is a very interesting work done by an Oxford team, which you can find on internet, who compared the government stringency index based on 23 indicators about restrictions. I mean mobility restrictions, closures of shops and bars and schools and so on. So 23 indicators were compared week by week, and I took out here the 4 countries which are concerned. You can find any country in this publication, so I think it's a very interesting tool to look at what every country has done compared to its neighbors, actually. And you can see here that the black curve, which is the Luxembourgish curve, shows that we had globally a more liberal policy during the whole COVID story. During the second wave, our shops were opened, people could move around, but so the economy was suffering less, and this is probably the explanation why our GDP fall by 2% or even less instead of 5 or 6 in many other countries. So the economy was going on and still working. A lot of teleworking, of course. So the lessons learned. In Luxembourg, mobility of patients is, I must say, our regular practice. All cross-border commuters have Luxembourgish social security, so even if we have only 600,000 residents, we have health insurance for the commuters and their families. It is more than 2 million people. The question in this COVID story was our first concern was the mobility of our nurses and doctors living abroad, not especially far away, but still abroad. And we had to deal with special authorizations to cross the borders. We offered overnight hotel accommodation for these people to avoid too many border crossings and so on. Nevertheless, we realized that the solidarity between countries was essential. There was exchange of equipments, there was exchange of data, there was exchange of experiences. We had a French plane on the Luxembourg airport who were coming to fetch French patients to fly them to Toulouse, and we had many contacts which were very effective, I must say. So I believe that if we want to increase our performance, we need to have some new view on what we call regions and not only nations. What is a region now? That is the big question. I think there are something like 70 identified regions where Catriona knows these subjects much better than I do. But the question is, what does it mean? I cannot say that in Luxembourg is cultural because we have 4 languages. I cannot say that it is purely geographical or purely economical, but something defines these regions, and this is an interesting topic to review these definitions after the COVID crisis. So final observations, borders don't stop viruses. Closing a border definitely is no solution for nobody. The University Hospital in Geneva had exactly the same problem. So we run a region, and the decisions we have to deal with come from Paris, Brussels, and Berlin, and that doesn't make things much easier. So we need some sort of a regional governance in these kind of situations. We were not prepared to this pandemic like most of the places in the world, but I think this is one of the lessons we have to learn. And in the end, and I think the Swiss colleagues would be interested also in a unique European social security card, which could well be a first step and a first ambitious step to guarantee mobility of patients, which is, I think, essential in Europe. Thank you very much for your attention.
Thank you, Philip. And while our technical team are preparing for the next speaker, I'm just going to pull out some of the things that struck me about your presentation. I think one of the most important things that the pandemic taught anyone in healthcare is that when you're on a border, abroad is local, and that is the contradiction. That is where centralised policy is felt most acutely in border regions, and longer term, those issues result in things like health inequalities in border regions. But also you get this great creativity on border regions, as demonstrated by Luxembourg, not only in their contribution of the Schengen Agreement to the rest of Europe, but also in the recognition of the interdependency with your land borders, and working with that. And that particular type of flexibility and creativity is very common to border regions across Europe. Defining regions can sometimes be a problematic thing because we don't like drawing more borders around places. But I do take your point that I think it's also possible to work with positive uncertainty, but I think as the ABR, we certainly recognise regions as places where people feel attachment to,
Okay. Yeah.
which may not be defined by borders. So that's something for later discussion, I'm sure. Also very struck by your remark about data and the essential role that data plays, not only in facilitating urgent care, but possibly in the future dealing with the elective care crisis that Europe now faces. So the importance of having data that can be utilised and interrogated across borders, I think, is something that we're going to see a lot of discussion about in Europe on patient mobility. I think I would now like to move to introduce our second speaker, who is Dr. Zim Uzbek, who is the head physician, a specialist in cardiology in Völklingen in Germany, close to the French and Luxembourg borders. You're very welcome, and thank you for joining us, Zim. We're going to go to your presentation now.
Good afternoon, ladies and gentlemen, and welcome to everybody in Barcelona, in Europe, or wherever you may be attending this session. Let me first thank IHF for inviting me to this excellent congress. I feel myself very privileged. Can I have the first slide, please? Yes. The topic I shall report about is our experience during the pandemic situation 2020-2021 in France, in our neighborhood just behind the border in Grand Est, especially in Lorraine. The basis for this cross-border collaboration during the pandemic was that we have since 2013 a collaboration with the French health authorities to treat French patients suffering from STEMI in our center. This treaty has been successful as the next department of cardiology is about 50 kilometers far away in our institution located just behind the border. Based on the experience with this disease of STEMI, which means ST elevation myocardial infarction, we were asked to help in COVID-19 patients as our French colleagues were short of mechanical respirator capacities on March of 2020 when the pandemic arrived on the other side of the border. As two of our colleagues were permanently working in the hospital Marie-Madeleine in Forbach, we knew about the disastrous situation there. In our heart center, we have 3 intensive care units, one for thorax surgery with 16 beds, 2 for internal medicine with 16 and 12 beds respectively. In an emergency situation, we are able to recruit 70 beds in total. The unit with the 12 beds was chosen for COVID patients. Thus, the unit was totally empty as the request from France arrived us. We had no German patients at that time. There was no hesitation and no debate about the question if we should help but only about how we could help our friends in this miserable situation. A major obstacle was that the border was closed by the German federal government, thus it was not possible to cross it. In the same time, the Ministry of Health of our state, the Saarland, announced a warning that it was expected that the pandemic situation would arrive within 1 to 2 weeks in our area. Hospitals were ordered to prepare themselves to face the situation and take precautions, thus to be able to treat every single patient with a COVID infection in hospital. In addition, our hospital was determined to become one of the 3 main backup hospitals for artificial respiration in the state. We were ordered to overtake patients from other hospitals on request. From 25th of March to November 2020, 11 patients were referred to our from 4 French hospitals near the German border. To cross the border with the patients, transportations was initially only possible after several phone calls. These calls were between the Saarland state government and the Ministry of Interior in Berlin and the federal police protecting the border respectively. All patients referred to us were on artificial respiratory therapy, and indeed their health situation was far away being promising. One patient died almost at his arrival. His return to the mayor's office of the city where he came from was also a drama for itself, as the border police didn't let the French funeral company pass the border. You should know that in France, corpses are stored first in the mayor's office until they are allowed to be buried. All other 10 patients were extubated after several weeks and sent back to the hospitals where they came from. Thus, this cross-border collaboration was successful from the perspective of the patients. 10 patients' lives were saved. As we heard that Forbach Hospital was lacking of respirator machines, one of our colleagues who used to work there regularly took one respirator machine and brought it to the hospital of Marie-Madeleine by his own private car. The idea was perfect, but is a pity not the result. The plugs for pressure air and oxygen in France are others than in Germany. No adapters were available to overcome this obstacle. What have we learned? To help across the border is feasible and not difficult as long as bureaucracy does not hinder the efforts. The collaboration is facilitated by knowing the physicians each other by formal cooperations. Thus, cooperations even not absolutely necessary and professional discussions will be helpful in case of catastrophic situations. Last, physicians must tell the politicians how to help and encourage them to do so without hesitation, as long as they fulfill of own duties are guaranteed. As we heard, there is a committee for standardization in Brussels. The plugs mentioned above for artificial respirators are in focus of this committee since more than 10 years. Until this committee finalizes its ideas, hospitals near the border should store 10 to 25 adapters to overcome the differences in plugs. Thank you for your attention.
I think you've very clearly demonstrated in the account of the urgent care collaboration that you were involved in the importance for next time of protocols that cover not just paramedic response, but actual urgent care collaboration and patient transfer, but protocols that actually override whenever borders are closed. The story of the border closures, I know ABR is aware of numerous accounts where patient transfer wasn't possible, where patients were being transferred in the forecourt of filling stations on the border, all sorts of things like this. So the importance of protocols that facilitate the kind of collaboration. And I think it's very important to remember that this isn't a minority sport. This is about patient safety. And ultimately, as a result of these collaborations on the ground, lives are saved. So there is a very, very high stake in getting this right the next time round and preventing harm. And the role of politicians in regions also to be able to understand what those issues are and also to support their colleagues in the healthcare sector, again, is something that we think is going to be part of our future conversations on cross-border patient mobility. So I would like to move next to our third speaker, who is Mr. Antoine Grassa. Antoine is the ambassador and diplomatic advisor to the prefect of the Grand Est region in France, and we are very pleased to have also had support from the Région Grand Est into the ABR study on patient mobility. So you are one of the regions which has, again, multiple borders, and you probably have a lot in common with Luxembourg in that regard. So I'm going to go now to the presentation of Antoine Grassa. And I would remind the audience that you can send in your questions and answers on the Congress app. Thank you.
Good afternoon, Mrs. Chairman, ladies and gentlemen. Antoine Grassa speaking. I am the diplomatic advisor to the prefect of the Grand Est region. It's a pleasure for me to be with you today, even on distance. And I would like to thank the Untitled Hospital Federation and the Federation of Luxembourgish Hospitals to invite me to sit on this panel. My presentation will focus on the special challenges created by the sanitary crisis, the COVID-19, for a cross-border region such as Grand Est, on the pragmatical solutions we had to implement in order to preserve cross-border mobility, and on the lessons learned. Maybe it's good, first of all, to have an idea of what is this area, this Région Grand Est. Let's have a look at the map. As you can see, the border is the black line. It is 4 borders with Belgium, Luxembourg, Germany, and Switzerland. And the red lines show the regional organization implementing this cross-border cooperation. Grand Est has been very heavily struck by this sanitary crisis in March 2020. The number of people admitted in hospitals increased very sharply at the beginning of March 20, as you can see, and also the admissions in intensive care units were extremely high, and we were very rapidly overloaded. So we had very serious difficulties in receiving the people. And on the top of that, the neighboring countries, and especially Germany, took strong containment measures and closed their border very rapidly. On the 16th of March 20, the border with Germany closed and was reopened only 3 months later. And then later on, 1 year after, for instance, at the end of March 21, Germany decided to put France in a special category where they should have very strict measures of testing, for instance, and that lasted in March until April. So this created a huge problem in this region where all the people used to live with the cross-border areas. Think that 170,000 people work on the other side of the border, 100,000 towards Luxembourg, 70 to 50,000 towards Germany, or they also have to cross the border to meet familiars or to take children to school. So people had forgotten that the border existed, and they were suddenly reminded that they had to deal with it. So we had to adapt. And in order to cope with all the problems created by this unprecedented situation, there were some meetings which get organized very spontaneously on a daily basis. First of all, one day when it was the hardest moment of the crisis, between authorities, administrative and health authorities, just to concert and see what measures could be taken. Later on, this mechanism of consultation became organized more strongly on a weekly basis. There was a video conference every Thursday at 8, chaired by the prefect of the Région Grand Est, with the pertinent authorities on every country. You have there a map. On the French side, you had the prefect of the region, the regional health agencies, or regional authority, which are the authorities in hospitals, for instance, also local authorities in the department. On Germany, Ministry of Home Affairs, whose representative is sitting in this crisis committee of Germany, Ministry of Health, Ministry of Foreign Affairs, and the Länder, and Switzerland, Public Health Office, and Luxembourg also ministries, health and greater region. And in Belgium, the Walloon Minister President. So this mechanism was very useful for us to exchange information, first of all, on the situation of the crisis. And you have there an example of this sort of figures we were exchanging, mostly the incidence rate. So it was useful to exchange that between all of us. And then also consultation on how to anticipate the measures which had been taken. For instance, when Germany decided to enforce testing obligation at the border, we had to, for every cross-border worker, commuter, we had to make sure that there were enough testing doses in the rear. And also, it was a way of anticipating the measures that were to be taken and bring that to our central government and central authorities, and try to have some flexibilization. And one of the major decisions we took for flexibilization was to consider that there should be no special control on people doing only a 24-hour stay across the border and for work or compulsory reasons like working or going to a doctor or to a hospital. We had also extraordinary meeting of some regional organizations like the Committee for Cross-Border Cooperation between France and Germany. So this was the organization, very pragmatical. And finally, what are the lessons learned? The first one is that we had a need for improving our common understanding of the statistics, because in many cases we were very surprised by the statistics that showed very strong differences between France and Germany, for instance. And then we thought we had to improve the long-term cooperation precisely by creating an observatory of pandemia. That was decided in the Franco-German council minister, and also improving common capacity building between the sanitary system. So this is, in the great lines, what we did in the Grand Est region to face the challenges of the sanitary crisis. Thank you very much.
Thank you, Antoine Grassa. And before I move to the next speaker, and while our technical team are preparing, I just want to again reflect a little on the challenges that were described by Antoine for the Grand Est region of France. And we also know that the Grand Est region of France has shown incredible leadership in developing a roadmap to health for really augmenting its overall approach to cross-border healthcare collaboration, not just with its neighbours, but in the context of the Grande Région, which both Luxembourg and Grand Est France are part of, and which we saw in a map earlier in our discussion. So these areas are very much areas where you have large populations and where data is going to be one of the key enablers of healthcare cooperation, and possibly healthcare cooperation beyond urgent care, I would argue. And certainly the Grand Est region really has the opportunity to show how smart regions can be developed that also involve health. I think there is, in European policy in general, particularly in regional policy, we have a focus on the issue of smart regions and spatial planning data. It's very important that we recognise that health data is going to be part of that data that we need to be able to see and understand and use at regional level. So health is very much part of the Smart Regions agenda and the digital innovation agenda going forward. So I'm going to introduce our next speaker, who is Ms. Melissa Hanus. Unfortunately, Melissa is not able to stay for our discussion, but she is the youngest member of Parliament at the Chamber of Representatives of Belgium. She's joining us today from Glasgow, and where she's been discussing other issues of sustainability and just transition, again, of which health is a very big part. So we're going to hear from Melissa about some research that she has conducted in relation to cross-border patient mobility involving her own community in Belgium.
Hello, I'm Melissa Hanus, a Belgian MP. So let's go with my presentation about cross-border health and medico-social cooperation as a European integration instrument. So in Europe, in the field of health, initiatives have made it possible to improve access to care, promote the exchange of both experiences and good practices, and support prevention and patient education actions. Thus, within the framework of Belgian cooperations in the field of health, the border area is meshed by cross-border health territories. In the Grande Région, promising initiatives are being deployed, like those developed in the Franco-Belgian area, which undoubtedly constitutes the model in Europe recognized and supported by the European Commission. So the construction of Europe has erected a feature of international social law that is unrevealed worldwide. The European regulations for the coordination of social security systems. The mechanism for coordinating social security systems is one of the basic instruments of the European social model. Cross-border health cooperation, as it has been deployed in the Franco-Belgian border area, uses the mechanism of this European social protection. So over the past 3 decades, the 5 Interreg programs that have been implemented have made it possible to develop projects that improve access to care and that create synergies between border care systems for the benefit of patients. Interreg programs give project operators legitimacy for action while providing them with financial support to coordinate cooperation initiatives. So the inter-hospital cooperation agreements that have emerged in the Franco-Belgian border have removed administrative and financial obstacles. Nearly 20 inter-hospital agreements have been set up to respond to the saturation of intensive care to treat patients suffering from ophthalmological conditions, chronic renal failure, or allow them access to magnetic resonance imaging. So during the Interreg Program 2, a study on the joint use of French and Belgian social security cards, transcards, made it possible to structure the first Franco-Belgian and European cross-border health territory. So for example, French social security policyholders were able to use their Sésame Vital social security card at Chimay Hospital, Belgium, as an example. So the establishment of a cross-border health cooperation framework agreement between France and Belgium has proved the necessary cooperation process. This first framework health cooperation agreement in the EU served as a model for partnerships. So these devices are in the line with the spirit of the European legislator who encourages states to develop enhanced cooperations. So the signing of the framework agreement stimulates the creation of cross-border health territories. So the ZOAST, Organized Cross-Border Healthcare Access Zones, the structure of which is based on the idea of cross-border healthcare basins. So since 2015, the entire Franco-Belgian area has been covered by 7 ZOAST, as the picture. So, in parallel with the development of health cooperation, the Urgent Medical Aid Agreement, Franco-Belgian AMU, has been established. In order to reduce the free medical interval time, the French and Belgian Mobile Emergency and Resuscitation Services, the SMUR, now operate on both sides of the border in the territory of the neighboring country. So this means that a SMUR located on the side of the border can take charge of a patient located on the neighboring border side. So for decades, elderly and disabled French people have been accommodated in Belgian establishment, mainly in the French-speaking part of the country. So today, it is estimated that 8,500 French disabled people stay in one establishment. So these findings have encouraged the adoption of a cross-border regulation system for this mobility. So in 2010, a proposal for a medico-social framework agreement was drawn up between France and Wallonia. This framework agreement concerned disabled people accommodated in specialized establishments. So the Grande Région brings together the Grand Duchy of Luxembourg, Lorraine, Wallonia, the Saar, Rhineland, Palatinate, and the German-speaking community of Belgium. So recently, the CESGR adopted a motion to create a space for cooperation in health following the impact of the health crisis and to promote mobility in the Grande Région. So in this spirit, we should see soon the birth of a new health treaty between Grand Duchy and Belgium, in which I'm personally involved. So in this way, it would only remain to negotiate an agreement between Germany and Belgium and between Germany and Luxembourg, so that the Grande Région is endowed with all the legal basis necessary for the deployment of cross-border health cooperation in the region's entire territory. And to conclude, the vision of a cross-border area as an area of innovation, cooperation, and integration results from an institutional development and the Interreg community action programs. So by stimulating the establishment of cross-border cooperation projects, the various Interreg programs have enabled actors and institutions or organizations which share objectives in similar fields of activity on both sides of a border to meet and develop actions and projects enriched by their specific know-how. So, however, despite the good intentions of those involved in cross-border health, the centralizing and planning trends in certain member states constitute threats to the maintenance and development of this humanist approach born and supported by the European Union. So thank you for your attention. Thanks.
Thank you, Melissa. And again, while the team is preparing for our final speaker, I think it's important just to pull out some of the points that Melissa made. One is the importance at local level of there being arrangements between healthcare providers, exemplified by the ZOAST agreements, which actually predate things like the European Cross-Border Healthcare Directive, but also the importance for patient rights to cross-border care of local arrangements being in place on borders so that those patient pathways are created across borders. But equally, it's also important that national agreements enable those and that national administration and bureaucracy enables that action at local level. So I think that's where the Europe of the Regions agenda comes in, to understand how everyone can pull in the same direction instead of these operations being caught between large policies in one state or another. The other thing that she mentioned was the role of the Interreg programme in supporting very early healthcare collaboration and in building capacity. I think it's important to note that the Interreg programme comes from the European Regional Development Fund, itself not a health fund, but it has been very instrumental in building the initial capacity. The big challenge is how do we translate that innovation into business as usual within the health sector and within the health administration and policy arenas. And then finally, she also referred to the mechanisms again that exist at European level, which are the Healthcare Directive for planned care and the Social Security regulations for a wider range of care, including emergency care. Those mechanisms exist for every member state to make use of, and the question is then what happens on the ground to make those possibilities a reality for patients in both urgent times and then beyond the pandemic. So I'm going to move to our final speaker, who is my dear colleague, Martin Guillermo Ramirez, who is the Secretary General of the Association of European Border Regions, who is joining us from Berlin. AEBR has offices in Berlin and in Gronau in Germany. And after Martin's presentation, we're going to go to questions to the various speakers, which I will ask in order. So if anyone has questions they want to send in online, please do it now, and we'll pick those up. And in any case, I have some of my own questions for the speakers if we have no questions from the floor, so we will not be stuck. Martin Guillermo Ramirez is our next speaker. Martin, you're very welcome.
Hello, dear participants in this roundtable. I have the pleasure to represent the Association of European Border Regions, which is an organization which is 50 years old in this year. In all this time, we have been promoting the interest of European border regions, but also of cross-border regions, which is a special type of structures which are spotted along most European borders. We were invited to this very interesting roundtable to talk about our favorite topic, which is what's going on with cross-border cooperation and collaboration and what will happen. And it's clear that the pandemic has made a strong effect on our structures, but even on the perception of the borders, including the internal borders of the EU, which are the main or the most interesting place for cooperation. We say that this is the optimal environment. After 30 years of European territorial cooperation, more than 60 years of European integration, the cooperation in optimal environment is considered to be there. But the reality is that the COVID pandemic put everything under a big question mark. So we have to face, on the one hand, major challenges currently in European border areas, like many of them are rural, peripheral, so there is brain drain and difficulties to access to ICTs, etc. Then the general obstacles or general challenges like climate change and the need to transform our ways to understanding energies, and then across borders. But it is also true that these areas within the EU are the laboratories of European integration, and there are a lot of positive stories every day. But then the pandemic came, and we saw that, again, after all those years of European integration, the first idea always is closing the border. So you have your population confined, but then you close the border. The good point is that the second idea they had was 24 hours later was to open. When I say they, I mean the nation states who have the power to open and close borders. Then they had to open in many cases in 24 hours or even before, because they identified that there were a lot of essential services that are taking place across the borders, especially in the EU, but not only. And there are doctors and nurses crossing the border every day to their workplaces across the border, or there are farmers, etc., etc., etc. So, but still, even in the third wave, there were, again, border closings, creating a lot of troubles. For instance, all those truck drivers trying to enter the UK just before Christmas. So we have made a follow-up with our other networks, with our members, border regions all over Europe, paying attention to the different measures implemented by the European Commission, for instance, like the green lanes, things like that, but with a lot of attention, of course, to the attitude of the nation states. And here we have made plenty of recommendations on the need of a cross-border coordination, which is very much needed, much further than the Commission. We need the involvement of the states, which are, at the end of the day, they are sovereign to make their decisions. So we are happy because despite the pandemic, cross-border cooperation and the cross-border interaction is included in most of the political agendas. But we think that for how long? What's happened with the pandemic is over. It has shown that like climate change, the viruses also, they don't understand human borders. And we have to understand that we have to face these challenges together. Well, we as ADR, we have several priorities. One of them for the future is to have citizens prepared to do territorial cooperation, to work across borders on a daily basis. To this end, we are implementing for the European Commission a project called Interreg Volunteer Youth, which is open to all young people until 30 years old in the EU, in the neighborhood countries, in the pre-accession countries to be deployed in Interreg projects, which are also projects of territorial cooperation in these territories, in the EU, in the neighborhood countries, and also in the pre-accession. We have already deployed 700 young Europeans, and we are trying to create a new generation of Europeans close to the working at the grassroots level on territorial cooperation. A second project we are implementing, which is has been interested to implement it before, during, and hopefully after the pandemic, is B-Solutions, trying to identify legal and administrative obstacles to cross-border cooperation and proposing solutions. You can imagine how many of these have to do with healthcare, other public services, but also emergency services, a lot of all the issues of recognition of diplomas, of the permission for the ambulances to cross, and the driver of the ambulance, cross-border hospital, like the one in Cerdanya, with some issues related to staff, etc., etc., are among the 90 cases we have already studied, and we want to keep on identifying this type of cases in the coming years. We have a series of lessons learned, which are not probably a surprise, of the variety of obstacles, the need to tailor solutions, the need to make changes in legal frameworks, but also the understanding of current frameworks, which sometimes the solution is there, but we are not aware, etc. and etc. We don't have the time to go through, but we have more information available on request, of course. We have a series of policy recommendations which have to do with the increased capacity building, promotion of multi-level engagement, multi-level governance, and maximizing already existing EU tools and instruments. That there are several tools for the implementation of cross-border territorial cooperation, including cross-border collaboration. And last but not least, there is a strong focus on the EU institutions on the cross-border public services. Our question is, while we are achieving cross-border public services, let's try at least to provide in a good way the existing public services across borders, because even there are gaps that we have identified through these solutions and other exercises. But there are very good examples. So we have here just a short list: the hospital in Cerdaña, the tram in Strasbourg, where you can take it to Kiel in Germany, etc. and etc. So there is a promising time to implement these cross-border public services, and we will need also to engage very with the health community, with the transport community, with the labor community, in order to be able to think together across borders. This is our big next challenge for European border regions. I thank you very much for your attention, and here you have our contact data, etc.
Thank you, Martin. I think Martin's presentation shows the range of issues that every border region and every administration in the border area face, a full range of obstacles. And what we would like to do is focus our discussion now on specifically the innovations that took place in health in border regions during COVID, what we would like to keep, and what else is needed. I am not aware of any questions having come in online. I want to offer the opportunity to our attendees here in the room if they have any questions they would like to ask, and then I will put those questions to each of the speakers in turn as our technical team works to have the speakers up on our screen. Does anyone have any questions they would like to, or comments they would like to make from the floor? Okay, I'm going to go to each of our speakers in turn. I have two questions. I'm going to ask them each to respond, and I think that will probably take us to our time limit on the session. So essentially, these are the two questions for each of the speakers. So those of our speakers who are coming up on screen, if we could have our other speakers up on the screen now, please. That would be helpful. I'm going to go to Philip first and say, Philip, looking back on the last year or 18 months, what innovation would you keep and what else needs to happen?
Thank you, Catriona. The main innovation for me is in the mentality of people dealing with healthcare. I think we have learned to be flexible. We have learned to ask new questions and new sorts of questions every week. We have learned to manage our teams differently, to adapt from week to week. And this flexibility was really impressive. And I must say that all the traditional resistances towards hierarchy or corporatisms or whatever difficulties we have had before COVID in all sorts of organizations. I think there was an adaptation, an organizational adaptation, which was really impressive, and which means for me that we can do it if we want and if it's necessary.
So maintaining the kind of culture that lends itself to that flexibility and that adaptability.
Absolutely. People were open-minded, they were listening to each other, which is not usually the case. And so there were no breaks in the system, I think. There was a global dynamic, an enormous solidarity, enormous generosity. People were working without counting their hours and their efforts. I think that's for me the main experience.
And of course, the relationships of trust that all underpinned. Yeah.
Of course.
Well, thank you, Philip. I'm going to go to Dr. Uzbek next with the same two questions. What innovation would you keep, and what else needs to happen?
Thank you for the questions. The first thing what we have learned, or I have learned, is that the needs near the border is different than in the middle of a country. The capitals, as it was stated before, are too far away, and the politicians there are looking in a different way to the borders. They close the border, not knowing what does it mean to the people living near the border. They are not, they are not crude, or they're not doing something bad, but they're doing everything because they think it is good what they're doing, and just the opposite is the case. And therefore, near the border, there must be other regulatory regulation between the states than for the whole of the state between each other. This is what I learned during this episode, and this knowledge I would like to keep for further engagement. Thank you.
Okay, thank you, Dr. Uzbek. And you've made the important point that border regions experience policy making differently, and also maybe the places where different solutions can be found. So I think that's very important, again, to pick out. Antoine, you're next. The same two questions. What innovation would you keep, and what else needs to happen for Grand Est and the Grande Région, of course?
Thank you. I fully agree. I think there's another microphone on. Okay. I fully. I'm sorry. There is echo. Is there another microphone?
We can hear you.
Okay.
Yeah.
I fully agree with what Sam said already on the fact that the situation on the border is very different, and that it's important to have the governors think about it. The innovation I would keep is this intensive organization of consultation that we experimented in the Région Grand Est, not only through this mechanism which I described, but also within the Grande Région, and also within taking part of the Luxembourg Corona Task Force. And I think finally that if there is something to create, it would be a more harmonized instrument for European cooperation for the border regions. Thank you.
Okay, thank you. And we look forward to seeing some solutions and exciting discussions taking place in your region next year. And I know Grand Est is taking over the presidency of the Grande Région for the year. So I think there'll be some very positive discussions in the field of modern health cooperation. So Martin, same two questions to you. In health and in terms of cross-border health cooperation, what innovation do we need to keep, and what else needs to happen from the perspective of border regions and health?
Well, I think, hello everyone. Thank you to the IHF for inviting us to this very interesting session, particularly when we can talk to those who were working hands-on during the pandemic. Well, I think that we have learned a lot of things, but we were using, the mantra that we use always in ADR, thinking of Mario Benedetti, the famous poet from Uruguay, who said that when we thought that we had all the answers, then they changed the questions. And so this is something that is happening to cross-border areas all the time, but we have seen how member states, they have learned something during this pandemic, and this has been repeated by various of the speakers, that they have discovered that there is something happening across the borders. There is a civil society crossing the border. Look at the case of Luxembourg, with this terrible figure of 56% of the doctors and nurses are living outside the country. But we have the similar situation in many other borders. But still, the first idea is to close the border. So I think that the member states have to start to think that perhaps this is not the solution, that perhaps the implementation of the sovereignty is not the solution. And then we have to progress more. The answer is more Europe. We have to coordinate better. We need still a lot of standards. Another mantra we have in ADR is that the single market doesn't exist. We have a common market, but then 27 different views of everything. Look even at what the professors were saying about the different adapters, the different pressure for oxygen. Look, we need a lot of standardization, homologization, and coordination. And we have to rely on structures or agencies where we can put forward several measures when an emergency can. So the borders, closing the borders, are not the solution anymore. I hope we have learned about that, and then we will improve the European integration process, and this will be the real innovation.
Okay, thank you, Martin. I think there are some very important common points that are coming out of the discussion this afternoon. Obviously, the need for formalisation. Are you there? Did you want to come in again, Martin? Sorry, I think we'll...
We can't hear you.
I can't hear anything now. I've got people speaking to me. Are you finished, Martin? Would you like to say more? I don't know if he can hear me.
Yeah, they have mute PPT to avoid the echo, but now we cannot hear you.
Okay, so can you hear me now? Can the speakers hear me? Yeah? Okay. So pulling out the, pulling out some of the main points from across the presentations. One, healthcare collaboration across borders, as demonstrated during the COVID-19 pandemic, but true of the future as well. It is sometimes a matter of life and death. It is also, for the future, a matter of how we address health inequalities, which ultimately do impact on lifespan. And we know that border regions, generally speaking, are more likely to have populations with complex health inequalities. And while it may not be a question of urgent care, there is the question of how do we provide shared services in a better way for the citizens of border territories going forward in health, and not just acute urgent responses, but also preventative and population health-led responses. It's important to remember whenever central policy makers tell you that the border region stuff is really not a priority and it's a minority and it's such a small section of the population and there's such a small section of the insurance market that is about border citizens. It's important to remember that in total 30% of the European Union's population lives in a border region. So we are talking an awful lot of people. So as a policy issue, I think we shouldn't be discouraged from really looking at these solutions going forward. They do require the involvement of the subnational, the regional actors. I think what we're hearing very strongly is that there is an appetite in the healthcare sector for forming those kind of relationships across borders with colleagues and with health systems. I think there are ways in which the political and civic institutions of those border regions can help and support you and that's very important as we go forward as well. And then obviously there are some basic indicators about how integrated we really are. Some of that will be around data sharing. Some of that will be around simple consistency, such as plug fittings, but that's one very potentially serious indicator of how integrated we actually are. But also, when the plug doesn't fit, what else are we doing? What is our plan B? And does everyone know what the plan B is? And I think that's the wonderful flexibility and responsiveness that you get in healthcare, because if people don't know what the plan B is, then it's serious. So I think if healthcare can get these innovations right, then any other sector can do it. And that's something I have to take my hat off to healthcare professionals and managers. I'm not a clinician, but I did spend time working in healthcare, and I do see that absolute agility and ability to respond. So, and I think it's also important to remember that while Martin is understandably cautious about how popular cross-border policy and thinking may be in Europe at the moment, I think it's also very encouraging that the European Commission in July of this year recognised border regions in a policy statement to the Parliament, the Council and the Committee of the Regions, recognised the role of border regions as laboratories for European integration. And I think our colleagues in the health sector can take great encouragement from that. And I think also from our perspective and from AABR's perspective, you will find willing partners in your border regions to help you to get the kind of conditions that you need for collaboration going forward for delivery of those services to border populations. So I think I would like to finish on time if we can. It's been a long day for everyone. And I know I want to thank again the Luxembourg Hospital Federation for organising the session. Thank you to the International Hospital Federation and all of the organisation that went into this session. Thank you to our speakers for joining us, for all of their preparation. Thank you to the technical team on site today. I think we managed to get through this without any major mishaps, so I have to thank them for that. And again, if there are any queries that any of our online listeners have, if you want to follow up or get copies of presentations, please contact IHF. And also, if you wish to get in touch with any of our speakers, those contacts can be facilitated through IHF. So on that note, I'm going to wish you all a good evening, and thank you all for your attendance and your attention. And I'm going to give the last word to Philip from the Luxembourg Hospital Federation, because this is your session. Philip.
Thank you very much, Catriona. I just want to thank you for your excellent help, for all of us, for the presentation on this really interesting subject. Thank you very much for your support, and thank you very much also to IHF for giving us the opportunity to have this session on behalf of the Luxembourg Hospital Federation. Thank you especially to Catriona for her excellent chairing, and I wish a nice evening to everybody of you, and thank you for being there, and see you soon. Thank you. Thank you.